Good morning. Mr. Duncan, I think we're ready to begin with our next witness.
That's correct, my lord. We have Dr. Dermot Murphy ready to give evidence.
Right. Good morning.
Good morning.
Dr. Murphy. As you appreciate, you're about to be asked questions by Mr. Duncan, who's the counsel to the inquiry. First of all, I think you're prepared to take the oath.
Yes.
Simply sitting where you are, raising your right hand, can I ask you to repeat the words that I'm about to say?
Yep.
I swear by Almighty God.
I swear by Almighty God.
That I will tell the truth.
That I will tell the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Thank you very much, Dr. Murphy. Now, the plan for the day, I don't know exactly how long your evidence will take, but it may go over into the afternoon. In fact, I think it probably will. We usually take a coffee break about 11:30, so you can anticipate that. But I say this to every witness. If, for whatever reason, they want to take a break, they must feel free to do so. So if you want to take a break, we'll simply do that. But now I will hand over to Mr. Duncan and ask him to ask what he wishes to ask.
Thank you.
Mr. Duncan.
Thank you, my lord. Good morning, Dr. Murphy.
Good morning, Mr. Duncan.
Can I just perhaps begin by having you give us your full name, please?
Yes, my full name is Dr. Dermot Matthew Murphy.
And are you a consultant paediatric oncologist?
Yes, I am.
And where are you based?
I'm based at the Royal Hospital for Children in Glasgow.
And what positions do you hold there?
So I'm as you've already alluded to, I'm a consultant paediatric oncologist at the Royal Hospital for Children in Glasgow. I'm an honorary clinical associate professor at the University of Glasgow, and I'm co-national clinical director for the Managed Service Network for Children and Young People with Cancer.
Thank you. Dr. Murphy, could you, it may just be me, I'm having slight difficulty hearing some of what you're saying.
Is that easier?
If you maybe just sort of slide the microphone a wee bit towards you. And one of the things that we have to do here is speak unnaturally slowly, which might help us a bit as well. I've got some further questions about you before we move on to have some questions about the hospital and about your patients. I'll ask you this question. Why paediatric oncology? What drew you to that?
Yeah. So paediatric oncology is a privilege to work in. It's a combination of the most old-fashioned doctoring. So you're at the patient's bedside and the family at a time when they are at their most anxious and most worried and most concerned. And you combine that with cutting-edge molecular medicine. And so it's a fantastic combination of modern 21st century healthcare with very, very old-fashioned medicine that, Hippocrates or anybody else would have been practicing in ancient Greece. So it's a wonderful combination of the old and the new, and it's a total privilege to be allowed to do that.
And just picking up on the new, do I detect from your statement that paediatric oncology, in a sense, is quite a recent subspeciality?
Yeah. So probably only 35, 40 years old as a recognised subspeciality. And I think it's probably important to say it is a subspeciality rather than a speciality in itself. So in other words, we're both paediatric specialists and oncology specialists. So we're very niche, and we deal with the incredibly rare and incredibly unusual. And yeah, so it's relatively new as a speciality. Our organising body, overarching body within the United Kingdom Children's Cancer and Leukemia Group grew out of something called the UKCCSG, United Kingdom Children's Cancer Study Group, and we had our 30th anniversary about 2 years ago. So that gives you an idea of how long we've been going as a specialty.
Thank you. A couple of points that I think arise from what you've just said that you allude to in your statement. How many centres for paediatric cancer care are there in the UK, roughly?
So within the British Isles, there's 20 centres for dealing with paediatric oncology. So we're regionalised, and that's because we are dealing with stuff that is so rare and so unusual. So you need to have a large population to be able to generate patients so that we can keep our skills up.
And the further point that arises from that, I think that you also allude to, does it follow from that there's a lot of discussion with colleagues out with Scotland and elsewhere? Yeah.
So I think I'd take it a step back from that. So even within your own hospital, there's an awful lot of discussion that happens with your working colleagues, and that's medical across the clinical spectrum. So doctors, of which there'll be surgeons, radiotherapists, paediatric oncologists, but also physiotherapists, occupational therapists. It takes a whole team to look after a child with cancer. We can't do it on an individual basis. And all of those people will be specialists within their own right. So you'll have pharmacists, for instance, who are paediatric oncology pharmacists. You'll have physiotherapists who are paediatric oncology physiotherapists. So you're supported by highly trained, highly competent clinical colleagues. And even with that degree of support, there'll be questions that you are unable to answer with that group. And so we would then go out to colleagues either within Scotland. So we work very closely with colleagues in Grampian. We have joint tumour boards with colleagues in Grampian, so that's Aberdeen. So we will have that discussion with them at a weekly meeting. And if we can't resolve it or we think we need to get further discussion, we'll either talk to colleagues in Edinburgh or we will talk to colleagues who we know have a particular interest in the problem that we're looking at. That may be a disease or it may be as a consequence of the treatment that we're going to give. And if that expertise is within the United Kingdom, that's fine. If not, we'll go out with the United Kingdom. And paediatric oncology is a very small world, and I use that term judiciously. So, if there's someone in the States who is a recognised world expert, I will phone them or email them if it's someone in Germany or in Italy. And we meet one another regularly enough that you can have that kind of conversation. And even if you haven't met them personally, you will have a professional colleague, that you both know, and you'll make that introduction that way. So we don't have any, pride doesn't get in the way of delivery. What we are is looking after children with cancer who, if we don't get it right, will suffer terrible consequences. So we go out of our way to make sure that we get the best evidential care. And again, I think it's important to think that paediatric oncology and paediatric hemato-oncology is absolutely at the forefront of evidence-based delivered care. It might surprise you to know that an awful lot of healthcare actually isn't that evidentially based. Paediatric oncology absolutely is. Everything we do, we try and do from results of trials. Now, whether that's the combination of chemotherapy that we give, or when you time your surgery, or in fact the supportive care that goes on as well.
Thank you. And if we just take this question at a general level at this point, because it's one we will return to later when we start to look at the story, am I to take from what you've just said that as and when particular questions or problems or challenges arise, you would see, you and your colleagues would see that there's a network not just within your own hospital, but out with the hospital and worldwide potentially?
Absolutely. Absolutely.
Now, can I ask you some questions, please, about your patients? Can you tell us a bit about the cohort of patients that you look after?
Yeah. I look after patients with malignancies, so that's cancers, and those are cancers of what are called solid tumours and brain and spinal cord tumours. So that's any lump that you have anywhere in your body that isn't a blood cancer or a lymphoma.
Yeah. And the age range of your patients?
Is 0 to however old the hospital will allow me to take, which is up to about the age of 18.
And you've touched on this in your statement and indeed already in your evidence just now. The particular challenges from treating children are what?
So children get, so there's a biological challenge, and that is that cancers that children and young people get are very different to the cancers that you or I or adults may get. They're biologically different, although we treat them in very similar ways. So with chemotherapy, radiotherapy, surgery, and now immunotherapy. But they are different. The particular challenges then of our age group are that they're growing, so that the consequences of the therapy that we give is on a growing individual. So their potential for getting problems from their therapy is higher. We also have a unique problem, if that's the word, that most of our patients are cured or are curable, and therefore we have to consider what's the long-term consequences of their therapy. And this is coming back to them being growing individuals. So it's fine to cure them, but you want to cure them so that they're not deafened. You want to cure them so that their hearts are still working, their kidneys are still working. And that has to be not just in 10 years' time, but in 60, 70, 80 years' time. So if you like, that's the biological difficulty. The other consequence of doing cancer work in children and young adults is the developmental things. So communication with children and young people and their families is absolutely key to the delivery of healthcare. And the other thing that we have to bear in mind is consent, and we have to be able to give information in a way that the children can understand and the families can understand. And obviously, if you're 2, your level of understanding is different from if you're 7, which is different from if you're 10, different if you're 15. And so we have to tailor the way we deliver information to children and families dependent on how old the patient before us is.
Thank you. Now, I want to start to move through your evidence, if I may, and I'll take this chronologically.
Yeah.
We'll start with the period of the delivery of the new hospital, if we can put it that way. Now, we've already had some evidence about this, and we've already had evidence on the extent to which those who would be delivering care, like you and your clinical colleagues, were consulted about the plans and the design for the hospital. What would your position on that be?
So there was a degree of consultation when we were in York Hill. My reflection now is that our opinion may have been sought. How much it was listened to is a different kettle of fish. The unit that we ended up with was not what we would have considered to be what we would have liked in the beginning. There were things that we had in York Hill that we were promised would be present in the new unit that aren't present, and that's a shame. There was things like having co-location of pharmacy colleagues, having co-location of social work colleagues that make the day-to-day running of the unit much better and make the efficiency of the unit much better. Those things weren't delivered. And I think it's important to remember that we weren't designing a cancer centre. We were designing a cancer unit within a children's hospital. And I think that's different. I'm not sure that message was heard. And it's very difficult to quantify the impact of not having those things. I think it's important to say that our ability to cure patients hasn't been impacted, but cancer care is an awful lot more than are you cured, are you not cured? It's about how do you rehabilitate and how do you prehabilitate, and what's it like whilst you are an inpatient? And I think the patients that we look after in the west of Scotland, although they are physically more comfortable because the rooms are bigger and the bathrooms are great, certainly don't have the input from non-medical colleagues that they would have had in York Hill, and that's a shame. And simple things like a playroom, a schoolroom, all of those things are vital. You know, childhood is a lot more than just your health, and your ability to carry on doing schoolwork, your ability to carry on play is vital.
Thank you. Now, I want to just ask you about one particular aspect of the delivery of the hospital that has received quite a lot of evidence, and that's to do with its proximity to the nearby water treatment works or sewage works, depending on your perspective. Have you got any observations about that matter?
Yeah, certainly when the location of the new Children's Hospital in Glasgow was being considered, there were many sites that were thought about, and within the consultant body, and I think out with the medical staff, but I can talk for the medical staff. There was, you know, we would have preferred to have been on another site in Glasgow, and part of the reason for that is that being next to a sewage work as your place of work is not that pleasant. And yes, it certainly smells. I mean, we were told, and again, I think it's fair to say, we were told before we moved across that actually there would be remedial works to the sewage works, so that although it was currently smelly, it wouldn't be smelly for the new Children's Hospital or the whole new campus. You know, and this is not only Scotland's biggest hospital. This is one of the biggest hospitals in Western Europe, and I think most people, if you were asking them, would you build Europe's biggest hospital next to a sewage works, would say, well, that's a bit of a silly idea. You have to reflect that the Southern General was on that site. It's been on that site for 100 years or so. So, you know, there always has been a hospital there. But I think to have continued something unpleasant just because it's been going for 100 years is not necessarily a great idea.
Thank you. Now, just one further point on that. I take you in your statement to be saying that as far as you consider it and as far as you understand it, the impact from the nearby sewage works is around comfort rather than risk of infection. Is that right?
Yeah, absolutely. Now, I'm not qualified to talk about the risk of infection from sewage works. That's not within my training, but we were reassured that there was no health impact from that. And as I say, there's been a hospital on that site for many, many years, and the clinical outcomes from that hospital are no different from ones that aren't next to sewage works. So does it have a direct impact on our ability to treat young people, children, young people with cancer, in terms of outcomes? Are they dead? Are they alive? How well can we cure them? No, it doesn't have an impact on that. But it certainly has an impact on people who are working in there and families when they arrive. And for families who come to a supra-regional cancer centre for the first time, they're anxious, they're nervous, and they need to be able to trust the professionals in front of them. And if the first thing they're presented with is the smell of sewage as they get out of their car, then that's not a great start. But it's surmountable, but it's not a great start.
Thank you. Now, just picking up on something that you've said and that you say in your statement, I just wanted to clarify something. Are we to understand from your evidence that you understand there to have been advice from infection control colleagues that there was no infection risk?
That's my understanding, yes.
And when you say it's your understanding, are you able to say how you have that understanding?
Yeah, there's something called the York Hill, or was something called the York Hill Medical Staff Association, which was the body that represented doctors within the old York Hill. And when that body was discussing with managerial colleagues the site of the new Children's Hospital, it was brought up that, you know, are we sure it's safe next to a sewage works? And we were reassured that it was safe. So, yeah.
Can you remember whether you ever saw anything in writing or whether that was in...
Yeah. No, I didn't see anything in writing. And to be honest, I would have been surprised to have seen something in writing. there was there has to be a degree of trust between clinicians and managerial colleagues, and I wouldn't have demanded in writing that where I was going to was safe to treat patients. As I say, there has been a hospital there for a long time, so there are some things that I want in writing, but that wouldn't have been one of them.
It was probably my question. I was just wondering whether the advice from infection control was something that was communicated to you verbally only.
Yes, verbally only.
Yeah.
Yeah.
Now, I want to just ask you to help us clarify one further aspect around the move to the new hospital. And I wonder if I might have you just look at a section in your statement. So, Mr. Russell, it would be the statement bundle, please. I think it's at page 855. And it's paragraph 102. I wonder if we might just enlarge that.
Yeah.
If you take a moment to read that, Dr. Murphy, and tell me once you've done that.
102. Yeah, okay, great. Yeah. So what I'm alluding to there is that when we first moved into the hospital, there was I can't remember now if it was a 6-month or a 12-month period whereby, as I understood it, the contract was that, if we came across anything that was non-functioning, that we highlighted that, because that would be therefore remediated under the building contract. And if it was after 6 months or after 12 months and it was highlighted, then that wouldn't form part of snagging. So there was a real push that, if you had a loose tap or a light bulb that didn't work, or a door that wasn't working properly, that was highlighted so that could be fixed under the terms of the new hospital deal. And I say after that there seemed to be much less interest, and part of that is because if you are pushing to get things done and you come to a timeline and that's it, and you've then missed the opportunity to get things fixed, then you will be standing back a bit and saying, well, okay, fine, we've missed the boat there.
Okay, thank you. And just concluding this chapter of your evidence, I mean, just trying to capture things broadly then, and thinking about what you said in your witness statement as well. What would be your overall assessment from the perspective of the clinicians of how the planning and delivery of the new hospital went?
I think that, are you talking about the clinicians within the hemato-oncology group?
Yes.
Yeah, okay. So I think we're all disappointed that we didn't get what we were promised at the outset in our new unit. Very much we were told at the start that when you move to the new hospital, you will get, as a minimum, you will get what you currently have, and you may well have an improvement on what you currently have. And we very clearly did not get an improvement, and we very clearly did not get what we currently had. So it was disappointing in that sense. And we had to change the way that we worked to accommodate the change in the physical circumstances where we were.
And I'm thinking really about the process of consultation with you and your clinical colleagues. I mean, are there any observations or lessons learned that you think might arise from all of that? Yes,
I think that in any situation where you don't get the outcome that you want to get, you need to look at why that is, and a bit of self-reflection is helpful. I think we didn't engage with the new hospitals group as effectively as we could have done. I guess that's axiomatic, because if we had, we'd have got what we wanted. So to a degree on our part, we could have made our arguments more cogent. We could have been more constructively engaging with them. However, and I think we got lost. The other thing to say is I think we got lost in the minutiae. In other words, where are the plugs going to be? How many lights are there going to be in the room? As opposed to the big question about how many beds are we going to have? Are we going to have a seminar room? All of those kinds of things. I think the input we had from New Children's Hospital colleagues, architectural colleagues, right from the beginning wasn't as helpful as it might be. And we had an engagement with them that wasn't as fluid and as productive as it might be.
Thank you. Now let's move further on in the chronology and start the story from soon after the migration of patients to the new hospital. And what I want to do is just to break this up into stages. And if we begin really with the pre-2018 stage, and we've obviously had quite a bit of evidence this week already about a number of these events. And so what I might do from time to time is simply summarise what we've heard and ask you for your observation, if you're okay with that.
Yeah.
If we start with 2015, you indicate in your statement, and I'm thinking about the summer of 2015, you indicate in your statement some awareness at the time of concern around the absence of HEPA filtration for BMT patients just shortly before the move. Is that right?
Yes.
Can you tell us a wee bit about that?
Well, I should say that HEPA filtration is a way of filtering air into patients' rooms, and it's particularly important for the bone marrow transplant patients. And Prof. Gibson was the transplant lead at the time. And there were walkarounds on the new site for clinical staff prior to patients coming across. And on one of those walkarounds, Professor Gibson and her PA noted that although the space was there for the HEPA filters themselves weren't in place. Now, that would have meant that the transplant patients couldn't come across. And if the transplant patients couldn't come across, then the rest of the ward couldn't come across. And if we weren't coming across, that would have meant that the rest of the children's hospital couldn't come across. So that's, that was a potential big issue. So I know that they got the HEPA filters rapidly and put them in place, but yeah, that was the issue with the HEPA filters.
Yeah. And did you have any awareness of further issues that were experienced in relation to the bone marrow transplant rooms, again, in the early part, or rather in the summer of 2015?
Not that I remember, but if you expand on that a bit, I might be able to talk to you.
Well, we've had some evidence that there was concerns around the presence of high fungal counts in the corridors and sealing of rooms, and concerns about pressure in those rooms.
Oh, absolutely. So the timings of when the fungal counts were done and when we became aware of pressure changes, I can't be certain about, but I can be absolutely certain about that we became aware that there were high fungal counts in corridors, in rooms, and that's not just in the transplant rooms, it was in throughout the unit. So that was a big concern for us.
Yeah. And did you have any awareness yourself about issues being experienced in the adult bone marrow transplant unit at that time?
Yeah, that's difficult to answer with the degree of certainty that I think you need, because I may well have been aware of corridor conversations or it was mentioned in passing. But when that was, I honestly can't remember. I was aware that the adult transplant unit was having similar problems, but what those problems were and when I became aware of that, I can't be sure.
Thank you. Now, what I'm really working up to is to try and understand whether you at the time had any concerns about the as delivered hospital at that point.
So again, it's really tricky to talk clearly about when does a slight anxiety become a bit of a concern, we really ought to take this seriously, to this is a major issue and we need to be working forward. I think in the first year we were in the Children's Hospital, it was a new move, it was a new place, and therefore anything that didn't quite work, was that because it wasn't, because it was a clinical issue, or was that because you were just bedding in and it was a new way of working? And in any new build or new car, there's always going to be things that you don't quite realize how they work. So within that first year, I think we were probably thinking, well, this is just, it's change, and therefore it's not a real issue with the build itself. The longer we were in and those things didn't go away, then we became more concerned that this was permanent, that this was not just because we were in a new build and we were doing things slightly differently, and it would all settle down. So I think the first year we wouldn't have been at a position where we thought this was really difficult. But you may well have been saying to one another, it's a bit odd. But that didn't translate into, we think there's a structural issue here. The longer you were in, the more you were concerned that there were problems within our patient population. And we were concerned about the physical build of the hospital. We didn't necessarily put those two things together at the time, but you became very aware that things weren't working as well as they should. Doors were sticking or sinks were blocking, and those kind of things. That wouldn't necessarily make you jump to think that's a cause of infection in children. You would see that our children were getting unusual infections, but you wouldn't necessarily have merged those two things together at that point.
Yeah, thank you. We're just thinking about the absence of the HEPA filters. I mean,
Yeah.
the way it's been described to us in the evidence is that the casings were there, but the filters weren't. Now, in your statement, and trying to put this reasonably neutrally, you expressed some surprise, if I could put it that way, about that.
Yes.
And does that really connect to what you just said, that the surprise is around the way that it had been built, rather than a concern about
precisely
risk?
And not having HEPA filters in place in a pediatric transplant centre is bizarre, right? I mean, it's like taking delivery of a car and there's no tyres on. And so then you do start to think, well, okay, if a problem then comes up further down the track, is this because that's an isolated issue, or is this part of a systemic problem because, they didn't put the HEPA filters in? So if they're not putting the HEPA filters in, what else are they not doing? And it's, as I alluded to earlier, we do like to think that we are an evidentially based speciality, and therefore you don't want to jump to conclusions. But it's, if you've got one thing that's so fundamental, like no HEPA filters being in place, and then the taps start not to work, or the doors don't close, or there's fungus growing behind walls, then you start to think, well, is this, the HEPA filters not being in, just a great description of how this hospital was built?
Thank you. Now, what I want to move on to now is to think about infection patterns.
Yeah.
And I'll try and, again, break this up into chunks of time. And we've had a bit of evidence on this, so I'll try and take this reasonably quickly. I'm going to deal with if we deal with 2015 to 2017, now the evidence, it may be easiest to do it this way.
Yeah.
I'll tell you what the evidence is thus far, and you can tell me whether you have any material disagreement with it. What we've been told this week so far is that in 2016 and in 2017, from time to time, there were concerns among clinical and microbiology colleagues about infection patterns.
Yeah.
Would that be your broad
Absolutely
record?
fine. Yeah.
And what was also said in evidence was that there was no advice at that point, or reported suspicion from microbiology or IPC of a suspected link to the built environment. Would that also be your recollection?
Yeah, that would be my recollection.
Yeah. And one of the things that Dr. Chowdhury mentioned in her evidence, and I think she was thinking in particular about 2017, was that she recalled also there being no, what she described as clustering of infections.
Yes. Because I didn't hear Dr. Chowdhury's evidence, it's difficult to totally agree with that statement. I think that it's certainly true to say that we were seeing increasing numbers of unusual infections, and quite when they became very obviously clustered, to use Dr. Chowdhury's word, I couldn't possibly say. So, yes, I wouldn't necessarily disagree with what Dr. Chowdhury is saying, but it's very difficult for me to agree with that without hearing the full thing.
That's reasonable. Thank you. And the other thing that we've had some evidence about, and I think we'll have more evidence about, is that I think in fact you touch on this in your statement, is that there was a possible hypothesis, and I put it no higher than that, possible hypothesis being considered at the time around Lyme care.
Yes.
Is that your recollection
Yes,
also?
absolutely.
Okay. Now, the next thing I want to ask you about is just moving towards the end of 2017, if you're able to cast your mind back to that. So we're about to move to what came to be called the water incident in 2018. So it's really up until that point. Were you aware of any concerns about the hospital environment being raised by infection control colleagues particularly at the end of 2017?
No.
Yeah. The evidence from Professor Gibson was that, I think the way she put it was, she was aware of an undercurrent, but not the detail.
Yes, I think that's fair. And I think that probably reflects where we all were as clinicians, but I don't think we certainly weren't aware that there was any formal link being made at that point.
Yeah. I don't think it's being suggested that a link was being made. I think the evidence or the suggestion may be that reported concerns about the environment were being made. And in this context, were you aware, and did you see at the time an SBAR that had been written by infection control colleagues towards the end of 2017?
No.
Now, if we move forward into 2018, and what I'll do is I'll try and do the same thing, which is I'll give you the précis of what we've heard, and you can tell me whether you materially disagree.
No.
So the evidence we've had so far is that, and I'm going to again break this down into stages if I may, focusing only on March 2018 at this point. The evidence is from your colleagues that there was a perception that there was an increase and a clustering of gram-negative infections, and there's references to cupravidis, stenotrophomonas, pseudomonas. Would that accord with your recollection? And the evidence also indicated, and this is all channeled through discussions at IMTs, some of which you were at that time, investigations were thought to indicate contamination of the water supply with bacterial and fungal pathogens in the Children's Hospital and in the Adult Hospital. Is that your recollection?
Yes, it is.
And there was a response, an early response following discovery of the first case at the end of February and March, which involved various restrictions and measures such as restrictions on the use of water, dosing of the water, mobile hand wash units. Is that?
Yes, absolutely.
Yeah. And ultimately, that particular IMT, we understand to have been closed at the end of March, really at the point, I think, where point of use filters had been fitted. Is that right? Yeah. But the evidence we also had was that what at least was being said at IMTs at that time is that there was a widespread problem in relation to the water, or rather there was a suspected widespread problem in relation to the water supply in the RHC. Is that your recollection?
Yes, that is my recollection.
Okay. Now, I want to just clarify one matter with you that came up in evidence, and that's in relation to an IMT that you attended on the 6th of March. Now, I know that you were given a reading bundle. Have you had an opportunity to read some of it?
Yes, I have.
Thank you. do you have a recollection of being at an IMT around about that time? And do you have any recollection of any concerns being raised by infection control about the fact that infection control had raised concerns with management and perhaps others, and the question of whether or not there had been a response?
Yes, I remember being in the IMTs at that point. Would it be possible to have the minute of the IMT?
Absolutely, yes. Mr. Russell, could we go please to bundle 1, and it's page 56?
Yeah.
Thank you.
So if we just first of all use the first page to identify the document, 6th of March, and I think we see that you are there along with Professor Gibson.
Absolutely. Yeah.
And if we go over the page, please, and if we, no, we're on page 57, and Mr. Russell, if we could enlarge the bullet point above control measures, so the one that says BG and DM queried, that one.
Yeah.
Thank you. Do you want to take a moment to read that, please?
Yes, please.
And let me know when you have.
Yeah.
I suppose my questions are really twofold, well, threefold. First of all, do you recall a conversation along those lines?
Yes, I do.
Yeah.
Yeah.
Now, my next question is, what was the concern that TI, I take to be Teresa Inkster, what was the concern she was raising?
Well, she's raising or she's echoing the concerns that myself and Professor Gibson are raising, that we are seeing unusual infections, and those infections are potentially environmental. In other words, that the bugs could be as a consequence of the building. And she is concerned that they may be as part of the building, and that she's looking into that, and she's telling us how easy or not, how difficult it is to make that association, to make that link, to prove that. And she's also agreeing with us that she thinks it's very important that these concerns, or that the knowledge of these organisms, and then the concern that they may be linked to the environment within the hospital, are passed up the managerial chain, so that our senior managerial colleagues, both within the Hospital for Children, but also within the greater estate, therefore QE, and then further up to the board, they are aware that there is a potential problem with what was and still is Scotland's flagship hospital.
I'm just thinking about what's written there. Can you confirm whether you recall Dr. Inkster saying that she had reported these concerns to the highest level in GGC already?
I don't remember her saying that, but the fact that it's in the minute reassures me that that's what she said.
Do you have a recollection of you and Professor Gibson having a dissatisfaction around this?
Yes.
Can you expand on that a little?
Well, we were concerned about the number and type of infections that we were seeing in our children. Sorry, that's not our children, in the children that we were caring for. And the concern is that our practice? In other words, that's alluding back to the way that we are either putting the lines in, or the way our nursing colleagues are handling the lines, or is that part of a bigger problem? In a way, if it's because of something we're doing, we can fix that, and we want to know Is there something that either we as individuals or we as a team are doing that is exposing children who are under our care to risk? And then we can mitigate that risk. But if it's within the built environment, there's nothing we can do on a personal level to mitigate that risk. And that information therefore needs to be looked at by colleagues who know much more about built environment and environmental infections. And senior managerial colleagues need to be aware, because if it is true, then they've got a big problem on their hands.
Are we to take, you say you have a recollection of this, are we to take from this, or rather, tell me this, does this indicate whether or not you had a concern that you were dissatisfied at what you were being told about the response from senior management?
I think we were dissatisfied by an absence of response to our concerns rather than what we were being told. It was probably that we weren't being told anything rather than we were actively being told.
Yeah, thank you. We can put that to one side. Now, again, just to maybe complete this part of the chronology, the evidence of Professor Gibson as regards what she took from the IMT process over this period of time was that she was concerned that there was something fundamentally wrong with the infrastructure. Would that accord with your recollection?
Yes.
Yeah. And she also said that she mentioned that Dr. Inkster was saying that she'd had no response to the concerns that she raised, and Professor Gibson considered that to be a very serious matter, and that she wanted that escalated to the highest level. Would that have been your understanding also?
Absolutely.
Yeah. Now, if we move then a little bit further forward in time, and I want to take the next chunk, which would be the summer of 2018 up until the Decant in September 2018. And I suppose I'll start with this question, which is what caused the Schiehallion unit to be closed. And I'll ask you, what is your recollection of the reasons why there had to be a decant from 2A and 2B?
Okay. So my recollection was that we had a documented increase in the number of gram-negative infections, and that many of those gram-negative infections were potentially environmental gram-negative infections. There was also a concern about the ventilation within the unit, and so the response was that we had to come out of 2A, 2B, the Schiehallion unit, to ensure that the infrastructure within 2A, 2B was fit for purpose, and that would mean that there would be work done with the physical structure of the unit.
Thank you. Now, that's very helpful. In your statement, you put it in these terms that there was unanimity among your clinical colleagues that, as you put it, you wanted off the unit at that point. Is that right?
Yes.
Yeah. And again, what I'll do then is I'll just set out to you a précis of what we've been told thus far. And again, you can say whether there's material disagreement on your part. First thing we've heard is that notwithstanding the remedial measures that began in March, there's been a return of a concern about infections in May and in June 2018. Would that be right?
Yes.
And in addition to gram-negative cases, there are a case or cases of atypical mycobacterium.
Yes.
There's a suggestion of drain swabbing disclosing various gram-negative bacteria. Is that right?
Yes.
And according to Professor Gibson, the advice coming from infection control at that point, and perhaps others, was that there may be a site-wide problem.
Yes.
And really just confirming what you've just said, that by mid-September, the staff were concerned that the unit was not safe. Is that right?
Yeah, absolutely.
And was it, if we were to really sum up the reason why there was a decant, was it that?
Yes.
Yeah, thank you. Now, I'm going to ask you a little about the choice of the decant options. Now, again, we've got a lot of evidence on this, and so I don't need to take up a great deal of your time on that, but you do, in your statement, raise one point which may be of some interest. You say that you say something about the possibility of having built a temporary facility. Can you tell us a bit about that?
Yeah, at the time, we were all concerned about the inherent safety of the ward we were on. And as I said, and as you've echoed, there's unanimity of opinion that we ought to move out of that environment. And the question was, where do we move to? And although we're paediatric oncologists and paediatricians, we're also doctors. And so there was a very clear understanding that if we were to move somewhere else, somebody else would have to be displaced. So that might be your mother or my mother not getting her hip replaced or not getting her coronary arteries stented. And so we understood there was a real issue that by moving, we would be displacing other activity. And there was also a concern that if there was a statewide problem, that moving off 2A, 2B, we would just move into an area that was similarly built and we would have the same problems again. So I have been lucky enough to have colleagues who have worked as doctors and nurses in the military. And, you know, so I am very aware that they are able to build hospitals very, very quickly in battle zones. And so I did suggest to managerial colleagues that they could very quickly and easily build, get the military in and build something on the QE site, but something completely separate from the physical infrastructure of either the children's hospital or the adult hospital. As I said in my statement, I can understand why that wasn't taken forward. But yeah, I mean, the underlying reason for that suggestion was because I had a concern that the whole of the infrastructure of the QE site was going to be replicated or would replicate the problems we were having on 2A, 2B. So by moving from 2A, 2B to another unit, either within the children's hospital or within the adult hospital, wouldn't necessarily solve the problem. And I think when we went to 6A, that proved to be the case. And within my statement, I refer to children, young people with cancer as canaries in the mine. And if you want to demonstrate, is my hospital fit for purpose, then this is a unique and vulnerable population, which will rapidly show whether the unit you are on is environmentally fit for them to be looked after. Thank you.
Now, a piece of evidence that was given by Professor Gibson and agreed to by Dr. Chowdhury was around respective responsibilities as between clinicians, management, infection control. And they both, it might be said quite emphatically, said that your job is the delivery of care in the built environment. The delivery of the built environment is somebody else's job.
Absolutely.
So I say that in this context, that insofar as there were discussions with clinical staff, clinical consultants, including you, about solutions, the decision of what was going to be done wasn't yours to make. Is that right?
Correct. Absolutely.
Yeah. But just on the point of the temporary facility, I think the evidence that we've already got from two of your managerial colleagues who are going to give us evidence next week is that the delivery time on that was relatively, at the time, thought to be considerable. I think maybe a period of 12 weeks was mentioned. Do you have a recollection of that?
Delivery time for
a temporary facility?
I didn't. My recollection was that it was not even seriously considered. So there was no discussion about delivery time.
Can you say whether? Can you say what the expectation at that time was as regards the likely duration of the decant?
Yes, we thought that it would be a period of weeks going into a month or two, and in a way that was an iterative process throughout. We always thought that we would be off the decant within the next couple of months. And of course, the next couple of months just kept on being the next couple of months.
Thank you. Now, just to something I'd just like to have you clarify in your statement. You say in your statement that at some point you had a conversation with the chief executive about whether it might have been better to build a new oncology unit for the children.
Yes.
Can you recall a little bit more about that?
Yes. So Scotland's got a population of 5 million approximately, and there's always been a discussion about how many paediatric oncology units should Scotland have, and that's not for this inquiry, but it would have been a great opportunity to build a whole new paediatric oncology, hemato-oncology department, including bone marrow transplant unit, either for the whole of Scotland or for a greater area of the west of Scotland. And lots of the concerns about the cost of a single site or of dual site would have been allayed because of the nature of the build. And the other thing is that, as I've alluded to earlier, and I think probably more importantly, the paediatric oncology unit, the children and young people's oncology unit that was built for us was not what we were expecting. And this would have been an opportunity for them to have rectified that.
Can you remember when this conversation took place?
No.
Was it relative to events? Was it around about the time of the decant?
Oh, yes, absolutely. Yeah.
Okay. Now, I'm still going to stay in 2018 and something that you've already touched on. Can you perhaps expand a little on what you recall or understand of the issue to do with ventilation that was identified in late 2018?
Can I have a bundle up to?
Of course, yeah. Well, I'll first of all just tell you what the evidence of Professor Gibson was, and you can say whether that assists you at all. Professor Gibson told us that in November 2018, so after the decant has happened, investigations of the ventilation system on the ward were reported as indicating that the non-BMT rooms on 2A were not positively pressured and were instead set to neutral or slightly negative. Do you have a recollection of that?
Yes, I do. Again, it's interesting that I'm aware of the degree of pressure that there is in the throughout the unit and the separation of BMT and bone marrow transplant and non-bone marrow transplant patients. I think if you were to talk to most paediatric oncologists in the country, they would tell you that yes, bone marrow transplant cubicles need to have bidirectional flow, so in other words, can be positively pressured or negatively pressured, and that there needs to be a pressure gradient in an oncology cubicle, but they certainly couldn't tell you about what the kilopascals of that flow should be, nor of the differential, and the fact that we're aware of them tells you all you need to know about the problems that we were having with flow, and it came as a surprise to all of us that the flow that we thought we were getting or should have been there wasn't there.
Yeah, the way that Professor Gibson, and if she framed her explanation essentially in the way that you have, I take you to be saying, I'm not a ventilation expert.
Precisely.
Yeah, but my understanding is as you've just set out.
Yeah.
Well, what she said was that she understood the point of a positive pressured room to be about keeping out particles and infections from immunocompromised children.
Patients. Absolutely.
Yeah. I asked her the question of whether, going back in time to 2015, whether she had understood that those rooms were going to be positive pressure. And I think, in all fairness, I think she was not able to say whether she had known that. What would your position be?
And mine would be exactly the same.
Now, there was a second matter that she mentioned, and she said that there was also an issue with something to do with ventilation ducts that were, and this again I think is the non-BMT rooms, that the ventilation ducts were connected to the ensuite toilet, and there was a concern about air being sucked from the toilet and ending up in the room.
Yeah.
Do you have any recollection of that?
I just have a recollection that that was a concern, but no more than that.
Okay. Now, you did ask to have a look at a document, and I'm going to have you look at a document now, please. It's really just to assist us in order that we get to see it in a sense. Mr. Russell, can we have from bundle 4, please, at page 132? Thank you. And yeah, that should be fine. And hopefully everybody can see that. Now, that appears to be an SBAR emanating from the Estates Department and going to the Director of Property Planning and Facilities Management. Would it be fair to take from that that's not something that's likely to have been sent to you at the time?
No. Sorry, yes, it would be fair. No, I didn't see it.
Yeah, thank you. And if we just look at the situation, well, first of all, the date of it's the 12th of November 2018. And it says, single bed room accommodation has a nominal air change rate of 2.5 air changes per hour, with the single rooms being neutral to negative pressure relative to the ward corridor. Just pausing there, that's the point about pressure that you've already told us about. This combined with the potential risk of air recycling from ensuite WCs to the supply airstream via air passing through bypassing the thermal wheel heat recovery unit introduce a potential for cross-contamination between single room suites. Now, just thinking about what's written there, do you have a recollection of any of that being said to you at the time?
No.
Or an understanding that that's what the issue was?
No. So, I mean, part of that is, I mean, this document kind of really neatly surmises when Professor Gibson and I talk about not being ventilation experts, a thermal wheel heat recovery unit, I have absolutely no idea what that is. What I can say is that we were aware there were concerns about ventilation, but not what those concerns were to this level of sophistication.
Mm-hmm. Can you recall whether the concerns at the time were of the sort that the ventilation system, as you would see it, as the treating clinicians and not as ventilation experts or infection control experts, but in that context, can you recall whether, from your perspective, the understanding of the ventilation system at the time was that it would or would not be appropriate to your patients?
I can recall that one of the reasons for the decant off was that there was a concern that the ventilation within the unit wasn't fit for purpose.
Thank you. Now, if we move on then in time, and I'm going to early 2019. Now, we will, in due course, Dr. Murphy, slow down a bit once we get to late 2019, where you're quite heavily involved in the IMTs. But if I may, I might just continue to proceed in the way that we've been doing.
Sure.
So what I want to ask you about, first of all, is if we put issues to do with infection and concern about risk of infection to one side, I'm quite interested to know about your impression of your colleagues and your patients' experiences on Ward 6A, thinking in particular about early 2019. Do you want to tell us a bit about that?
Yes. Can I ask, just for context, what you're thinking about how the patients and families found Ward 6A?
Well, let me take a step back. It probably was far too vague a question. Let me ask it this way. Can you ask the question this way? Can you say whether or not you considered that Ward 6A was a suitable ward for paediatric hemato-oncology patients?
So it was a suitable stopgap that meant that we could carry on treating children and young people with cancer within the west of Scotland and not have to send them to colleagues in Aberdeen or Edinburgh or Newcastle. So it was seen as preferable to shutting the service. And the infrastructure in terms of how the patients would have felt when we first moved in, the rooms were the same size and the bathrooms were all en suite. And I think it probably is important to reflect that that wasn't the case in York Hill. So that the kind of hotel infrastructure within the new Children's Hospital was, and within QE, was much better than we had been used to on the old York Hill site. And our ability to deliver chemotherapy, treat infections, do our day-to-day work was possible to do that. But it was a cramped environment. The space that was available for doctors and nurses and pharmacists and everybody else was much less than was required. It made working very difficult. Again, when we were there, it became rapidly obvious that the infrastructure on 6A had the same problems or similar problems to infrastructure on 2A, 2B. And I think I've alluded in my statement to the fact that we got so used to rooms being closed for remediation that you didn't even notice that the rooms were closed. So, I can't remember how many beds there were on that ward, but say there were 15. If 2 bedrooms were closed, you didn't bat an eyelid because it was an everyday occurrence that another room would be closed because, there was a problem with the sink or a problem with the toilet or there was increased fungal counts within the room. So 6A was a reasonable place to decant to on a temporary basis. That meant that we didn't have to send children out with the West of Scotland, but it was by no means perfect.
So just thinking about in terms of the ability to deliver care and putting risk of infection to one side, does it go back to what you said a moment ago about the duration, the 2 months becoming another 2 months?
Yes.
So had it been a few weeks or a few months?
Absolutely. And I think it goes back to 2 things. So if you think you're only going to be there for a short period of time, you're much more prepared to put up with things that are an irritant than you would if you told at the outset you're going to be here for 3 or 4 years. And the other thing is it depends on the metric that you're looking at. If the metric is, are you able to produce the same kind of cure rates for children with cancer, then the answer to that is, well, yes, we can. But that's not what 21st century medicine is all about. And the children and their families in the west of Scotland deserve to have a world-class environment. And it was very clearly not a world-class environment.
I detect from your statement that you are familiar to some extent, at least, with the evidence that the patients and families gave. And one thing that they all said, almost without exception, I think, about Ward 6A was, well, they painted quite a bleak picture of just thinking about those, as it were, non-clinical aspects of being on the ward. Is that something that you would recognise?
Oh, absolutely, it's something I would recognise. And I think that you cannot underestimate the impact of having a diagnosis of cancer in your child. For a parent, that's beyond their worst nightmare. To meet me, if you meet me as a parent, that's never a good thing, for the first time. And so they're already in an emotionally vulnerable place. Then you are told that not only are you not going to be in a children's hospital, there's all the things that go with being in a children's hospital, but you're going to be in a place because the place you should be being looked after has got the potential for getting your child infected. That's a really, really difficult place to be. And then on top of that, no playrooms, you are physically distant from things like just going down to physiotherapy. It's a much longer journey. Everything was made more difficult by being in a adult hospital in a ward that wasn't designed for either children or young people or children and young people with cancer. So I'm not surprised that the families found it particularly bleak. It was a difficult place to work.
And then just picking up on that and the difficult place to work and thinking about you and your colleagues, then one of the things that you mention in your statement and that we see mentioned in other statements and in the evidence is the multi-site aspect of the care that was now being provided. Can you tell us a bit about that?
Yes. So the bone marrow transplant patients had to be looked after on a recognised bone marrow transplant unit. And so that meant that they were on the adult bone marrow transplant unit, which was on the 4th floor, and we were on the 6th floor. And at one point, our daycare was in the children's hospital on the 1st floor in the children's hospital, and that made for inbuilt inefficiency. So you can't have children alone in an adult hospital environment without paediatric trained staff there. So you had to have paediatric nurses present on the adult bone marrow transplant unit. You had to have paediatrically trained doctors on the adult bone marrow transplant unit. And that means that they are therefore not delivering care out with their transplant patients because they are physically separate from the unit. So, for instance, if one of our registrars was, or let me start another way, when the transplant unit is embedded within the wider pediatric hemato-oncology unit, it means that when you're not actively looking after your transplant patients, you can physically go and see hematology patients or oncology patients if they become unwell. You can't do that if you're 2 floors away. So there's an impact on the number of staff that you need to have to staff your unit. And similarly, if your daycare is physically further away than it was, it means that staff are shuttling up and down between daycare, between the transplant unit and the hemato-oncology unit. So it just becomes more inefficient. It means that you have to have more staff to look after your patients in the same way.
Yeah. But one thing that has been mentioned many times, and you mentioned it in your statement, is around separation from services, and one in particular that had a lot of, seems to have attracted a lot of concern was separation from the PQ.
Yes.
Do you want to tell us a little bit about that?
Yeah, so the physical distance between the PICU, the Pediatric Intensive Care Unit, and 6A was greater than the physical separation between 2A and PICU. So in the Children's Hospital, PICU was 1 floor down from the Pediatric Hemato-Oncology Unit, which meant that PICU staff could easily come to the ward to do what you call pre-ITU work. So in other words, if we're concerned that a patient is unwell and is going to become more unwell, the way PICU medicine has evolved is that we get the intensive care staff involved early to try and prevent them going to the intensive care unit, so that you institute measures before the patient becomes really unwell to try and prevent them going to the intensive care unit. And it's much easier for ITU staff, ICU staff to come from somewhere that's relatively close to just have a look at your patient, professional hand-holding, so that you would have a discussion with your PICU colleagues saying, look, we're doing this, we're doing that, we're doing that. Is there anything else we should be doing? And that kind of physical separation made that kind of interaction more difficult. It also meant that if the patient needed emergency transfers, that again became more difficult. And again, for context, it's not unusual for pediatric hemato-oncology patients to become so unwell that they need to go to the intensive care unit. And that's part of our routine counselling that we say to families when they arrive, that's potentially one of the things that would happen. And that's because of the side effects either of their chemotherapy or because of their disease.
Dr. Murphy, it's entirely my fault. I no doubt know this. I think you're using the acronym PRC. Have I got that right?
No, sorry, PICU, Pediatric Intensive Care Unit. I'm sorry, that's my enunciation.
No, it's my hearing. Pediatric intensive care unit.
Yes.
Right.
And sometimes we'll call that ITU. That's the intensive therapy unit, which is an older acronym.
Yeah. I was expecting PICU, but I was somehow hearing PRC.
Okay. I have a similar problem. So transfer when the patients became unwell was also more difficult. It wasn't so difficult as to be a clinical compromise, because that wouldn't have been acceptable. But when you're talking about going with a potentially ventilated patient in a lift down 5 floors instead of down 1 floor, and down many corridors as opposed to one corridor, that becomes more tricky. And again, for patients and families, let alone for staff, that increases their concern. And if they've had to make that journey, it absolutely increases their concerns. So being physically separate from the whole of the children's hospital infrastructure was difficult. And PICU is a great way of modelling that, of describing that. But it's everything else that goes within being within a children's hospital. You know, if it wasn't important to have the adjacencies, we wouldn't have children's hospitals. We would have pediatric wards in adult hospitals. And one of the glories of working in Glasgow is that it is a children's hospital, and you have infrastructure and professionals that are solely dedicated to working with children and young people. And to be divorced from that was difficult. And it's simple things like if you want to have a discussion with your colleagues about any problem that your patient is having. So say, for instance, I've got a child whose blood pressure is concerning me. If I'm in a children's hospital, I will be walking through that, and I will bump into one of the renal physicians, and I'll say, oh, whilst you're here, listen, I've got this child. And they'll either say to me, that's great, and you're doing all the right things, or that's very interesting, I'll pop along and come and see that child. And of course, if you are absolutely concerned about a child's blood pressure, you will pick up the phone and talk to the renal physicians. But the fact that you're physically going out of your way to do that, and you're doing it at a later stage, is one of the reasons why being in a children's hospital makes all of these things much, much easier. So, and again, it's not just about other doctors, it's about social workers, it's about pharmacists, it's about occupational therapists, it's about all of the supporting infrastructure that goes to looking after an acutely unwell child or a chronically unwell child. And children with cancer have, I smile because it's my everyday, but they are extremely unwell. And you need to have a whole team looking after those patients. It can't be done by doctors alone. It can't be done by nurses alone. You need a whole team to look after them. And we were physically dislocated from that team, and it just made everyday working more difficult, and it deprived the children of the West of Scotland of the kind of services that they deserved.
Thank you. Now, it might be important just to mention one qualification or addition to that evidence which you mentioned in your statement, and it's again in relation to the PICU.
Yep.
And you've given us obviously a lot of evidence now about the challenges in terms of and I assume anxieties in terms of this sort of disaggregation or separation.
Yep.
But I wonder if you could maybe just help us with this. To what extent, in your view, were children ever actually put at risk as a result of that?
Yeah, okay. That's a really good question. And I guess it comes to defining what risk is, and whether it's excess risk and whether it's real risk. And so you can't have a PICU next to every child's bed. So, there will always be a physical separation of the intensive care unit from the other units within the hospital. And I think that if there had been if there had been a concern that our distance from PICU was so great that children were being put at an unacceptable excess risk, we wouldn't have moved. We would have just said we are too far away. So in between those two extremes, there's going to be an increased risk. And is that an acceptable risk? And what can you do to mitigate that risk? And we certainly had conversations with our intensive care colleagues when the move was mooted as to whether that would put our patients at excess risk. And if it did, what could we do to mitigate that? So, you know, for instance, it sounds silly, but we had signage put up so that, especially at night time, the junior doctors who were looking after the hospital at night knew where we were so that they could get to us quickly. So there's absolutely an increased risk, but it was a risk that we could mitigate. And I don't believe that our patients were put at an unnecessarily high risk because of that physical separation. But we absolutely needed to do things to make sure that that risk was minimised.
Thank you. Now, again, staying with early 2019, and I think we might make this the final chapter of your evidence before the break. You've given us now quite a bit of evidence about the challenges around clinical care and the delivery of clinical care and the impacts upon patients and families. What I would now like you to focus on a bit is perceived further problems with the environment and concerns about infection risk. What, if any, concerns did you have about the built environment in the early part of 2019 on Ward 6A?
Yeah. So, as I said previously, I was concerned that if we were, I'm going to use the concern word again, if we were concerned that there were environmental problems on Ward 2A, 2B, and we were moving within the same built environment, why would it be that this was not a systematic problem? One of the questions we had asked estates colleagues and managerial colleagues was, you know, are the problems that we're seeing on Ward 2A, 2B confined to Ward 2A, 2B? Are they throughout the Children's Hospital? Are they throughout the whole of the estate on the old Southern General site? And I guess reasonably they told us they couldn't answer that question with a degree of certainty, which meant that I was concerned that if we were to move within the hospital site, we would merely be moving to another place with exactly the same build quality problems that Ward 2A, 2B had, which was why I had earlier talked about could we not build something entirely separate.
Thank you. Now, I think you've already alluded to this in your evidence, and you say in your statement that it felt that there was, I think what you say in your statement is that regularly there seemed to be issues with rooms, and you mentioned sinks and toilets, that kind of thing. What about issues to do with patient safety at this time? Do you remember issues arising or concerns arising in early 2019 while you were on Ward 6A?
Could you expand on that a bit further?
Well, we've had some evidence so far, and you do mention this in your statement, and I'm not proposing to go into this in any detail, I'll reassure you, but we are aware that there was a concern. Two things. There was a concern, first of all, at the end of 2018 and going into 2019 about cases involving something called cryptococcus. And in addition to that, we've had evidence this week of reports from infection control about high fungal counts being found on the ward, and that in addition, investigation revealed an issue to do with the shower area.
Yes.
Can you tell us a wee bit about your recollection of those things?
I can tell you that I absolutely recall all of those things. I can tell you that we were doing fungal counts within rooms, and there was it was difficult to interpret those because there isn't actually an evidential base against which you can interpret the results of those things. But we were also finding that behind leaking showers, for instance, there was very obvious fungal growth on the walls. And so, yeah, there was a concern about the physical infrastructure on Ward 6A at that time.
Can I ask you this question, just on the fungal growth behind showers? And if you can't recall, please say, can you recall how widespread a problem that was?
No, I can't recall how widespread that was, but I can recall that it wasn't just in one room.
Yeah. And we know from the evidence we've had already this week that then came a point towards the end of January and into early February where there was a decant back to the Children's Hospital to go to the CDU.
Yeah.
Do you recall that?
Yes, I do.
How did you feel about, well, two things. I'll take them in turn. What was your impression or assessment of concerns around the building at that point?
Well, I think it confirmed my previous concerns that the whole of the estate had problems and it wasn't confined to Ward 2A, 2B. In some ways, moving back into the Children's Hospital, we felt glad about that because it made all of those adjacencies that we've been talking about earlier easier. But equally, we were going back into the clinical decision unit, which has a huge impact on the emergency room and their ability to function properly. And so whilst one is always, the primary focus is on the health of the children that you're primarily responsible for, we also understood that we were displacing other unwell children within Glasgow, and that doesn't make you feel good.
Just on the first aspect of what you said there, in your statement, what you say is we would have had concerns about anywhere on the Queen Elizabeth site.
Yes.
Is that right?
Yes.
And you say that every clinical area where we had been was proved to have defective build issues.
Yes.
Is that your assessment of that?
That was my assessment, yes.
Yeah. Now, just on the question then of the move back to the Children's Hospital, given that that was somewhere that you had left not that long ago because of perceived concerns.
Yes.
And given that there had then been a further concern about ventilation, did you have any concerns about going back to the Children's Hospital?
I think probably the best way to summarise how I was feeling at the time was I was anxious about the whole estate. And I was anxious that wherever we moved to within the Children's Hospital or within the adult hospital, we would uncover similar problems to the problems that we were leaving behind.
It may not be possible to answer this question, but are you able to describe to us or assess the level of your anxiety and that of your colleagues at that time?
Well, we certainly talked about and did transfer patients out of Glasgow for a while. So if you were a newly diagnosed patient, we asked colleagues in Aberdeen and Edinburgh to take over the management of those patients until we could be sure that the environment was more secure. And I think that shows the degree of anxiety that we had, that the physical infrastructure that we required to look after children with cancer wasn't there.
Thank you. Now, I'm about to move on to a further chapter. Dr. Murphy, my lord, I think this might be an appropriate point to break.
Right. As indicated earlier, Dr. Murphy, we've been taking a coffee break of about 20 minutes, and we'll do that now. We'll try and sit again at 10 to 12, and I would hope you have the opportunity for a cup of coffee. Mrs. Brown will take you to the waiting room.
Thank you very much.
Right, 10 to 12.
Please stand.
Mr. Duncan.
Thank you, my lord. Dr. Murphy, I was about to move to a new chapter, but I'm going to go back to the chapter we've just been on because I've been asked to clarify something with you.
Yep.
And it's really just to go back to this question of the perception and the impact of upon patients and families.
Yep.
And I took you earlier to accept the description of some of them that they had felt things were quite bleak on 6A, is that right?
Yes.
Now, the evidence that we had from time to time from a number of them was that, in fact, some of them felt institutionalised.
Okay.
Now, that was something that I put to Professor Gibson, and I'll ask you what your reflection on that would be.
Well, firstly, I'd want to know what they meant by being institutionalised. And that sounds pejorative, and it's not meant to, but it is it is a term that can mean different things to different people. I think if you're talking about the fact that you are isolated physically and emotionally, I can understand that because that's what they were. I'm very saddened to hear that families felt institutionalised. We weren't, as staff, made aware of that at the time. That term is new to me today. But I would certainly understand that emotionally it was an incredibly difficult place for families to be. I don't know if it's because if you have moved from one environment that's relatively accessible and friendly into another environment that isn't, that accentuates the feeling of isolation. It's difficult to say, but I can certainly understand why families felt isolated and alone on 6A.
Thank you. I think just to pick up on what you've said, I think my understanding of what was being said around the use of that word was that it was essentially, first of all, that sense of isolation. Mm-hmm. I think secondly, it was that sense of being cut off from the bits of the service that are, as you say, vital. Yeah. And I mean, one bit of evidence that I remember vividly was the description of one patient who had felt very strongly that they never ever wanted to go on to nasogastric feeding, but they felt that things just, the dial moved on 6A, things just became more difficult. So I think it was that kind of overall feeling of just being stuck in this place and enclosed.
And I can absolutely understand that. And I think nasogastric feeding is a good example, a good model to think about. And I'm going to take it away from that patient. I don't know who that was, but it's fairly common for children and young people with cancer to require what we call augmented feeding, which is nasogastric feeding, or can become nasogastric feeding. And we would endeavour to either start that very early so that you don't become cachectic and lose weight, or we would try and avoid it, and then if we need to step in, we step in. But that the starting of nasogastric feeding requires coordination between clinicians, nurses, dietitians, and to a degree pharmacy colleagues. And that is much easier to get that degree of coordination if you are all physically together in the same place. And I'm not surprised that families felt the degree of disconnect that there would have been when we were on 6A, not between ourselves and the family, but between ourselves as professionals. And that they may well then have reflected that either they got nasogastric feeding too early or they got nasogastric feeding too late, whichever it was. I can certainly understand why that would it would feel like that to families.
Yeah, thank you. Now, if we move on then to where I was about to take you, which is the period of the summer to late 2019. And again, I'll break that up into stages.
Yeah.
I think probably there's 3 stages that we'll look at. Okay. And the first stage is, and again, I'll do it the way I've done already, if I may, and you can just tell me whether you agree or disagree. First of all, I'm going to deal with a period where we understand there to have been restrictions as regards admissions to sick bay. And the evidence we've had so far this week and in other witness statements is to the effect that in the summer of 2019, there was a re-emergence of gram-negative infections, and I think there was also a gram-positive infection. Does that accord with your recollection?
Absolutely, yeah.
And in her evidence, Professor Gibson says that she considered or understood at least some of these, as she put it, to have been definitely hospital-acquired. Mm-hmm. Can you recall whether that was your understanding at the time?
Yes, it was. And we did have discussions with colleagues out with the department within IMTs about whether they were hospital-acquired or not. But the feeling from clinicians was that many of those infections would have been hospital-acquired.
Yeah, now that's helpful, Dr. Murphy, because it allows us to trail where we're going later. And where we're going to go after this is to look at the process of the discussion around that, to then look at the process of the ward opening up. And then at the very end, I'm going to ask you to help us a bit with what is an unusual or not unusual infection, and we'll look at that in a bit more detail.
Mr. Duncan, if I could just interrupt for a moment. Really a question of vocabulary.
Yes.
Because my understanding, which I would encourage you to immediately correct, is that one definition of a hospital-acquired infection is really simply by reference to time. If the patient has been within a hospital or maybe healthcare environment for 48 hours and an infection and acquires an infection, that would be defined as a hospital-acquired infection.
Yep.
And again, correct me if I'm wrong about that. That is really independent of the mechanism by which that infection occurred. So really just to help me, lest by adopting healthcare or hospital-acquired infection, one seems to be making an assumption as to source.
Yes.
Could you maybe help me with that?
Yes, and I'm not surprised it's difficult because the definitions are difficult and change depending on where you read them. And I was looking at this last night, actually. So there's a difference between a hospital-acquired infection and a hospital-associated infection, both of which are called HAIs. And there's also a difference between, which I think you're getting to, which is what's the etiology of this infection. So is it that the infection or the temperature occurs 48 hours after the patient has come into hospital, and therefore fulfills the definition of a hospital-acquired infection? But actually, we know that mum and dad have got a cold and brother's got a cold, and actually this is the same thing and it's nothing to do with the hospital environment. Or is it an infection that has arisen because of the hospital environment? And those two things are different and may have different names. So the terminology is tricky. Does that help?
It does, and maybe just with Mr. Duncan's help, we'll find out where the questions are specifically directed.
Thank you.
And I think what I would say is that when you're looking at tight definitions of a hospital-acquired or a hospital-associated infection, that's the realm of the infection control team and the microbiology team, and they will be able to give you very strict definitions of those things.
Thank you. And it might be useful to clarify where we are going at this stage. Later in your evidence, I'm going to ask you a bit to explain to us a bit about what you say about two things.
Yeah.
Whether patterns of infections were unusual, and secondly, whether, in your view, a link can be made.
Yeah.
And the reason I'm going to ask you about those things is that there's already quite a bit in your statement about those things, and I think it'd be quite useful to go over it. What I'm just trying to get at this stage is just a sort of broad understanding of what people thought. And it is, I think, quite helpful to just pause on the language that I had used.
Yeah.
If we were to put it in these terms, that as at this stage in the summer of 2018, was there a concern in relation to this increase in infections that you've already said that was being seen, that there may be, or there may be a hypothesis or a concern, might be the better way to put it, that it could be something to do with the hospital environment?
Yes, absolutely.
Yeah. And what we've also heard is that at this point, patients and staff were close to breaking point.
Yes.
And a perception by the staff that whoever was looking into this hadn't got to the bottom of the problem. Would that be right?
Yes.
And the way it was put in evidence was that the staff thought there may be, or were concerned that there may be something fundamentally wrong with the campus. Can you remember whether that's how you felt?
That absolutely is how I felt.
And against that background, what we heard was that over the summer period, a restriction of some kind, I think maybe as regards new patients, would that be right?
Yes.
Was put in place. Okay, so that's the first stage. Now, we also know that there were a number of IMTs over this period, and I'm now going to take you to two IMTs that occurred in August 2019, both of which you attended.
Okay.
Now, something that was mentioned to you earlier and that I've mentioned to other witnesses, we're very conscious that many, if indeed other than you and your clinical colleagues, many of the people involved in these IMTs will not be giving evidence in this chapter of the hearing. So we've been treading quite warily, and I guess what we're really interested in what we are interested in here is more around the processes and what was being said rather than anything to do with the personalities. So against that background, can I ask you to look, please, in bundle 1 at page 343.
Thank you.
And we've got an IMT of the 14th of August, and I think we see that you were one of the attendees.
Yeah.
And this was prior to there being a change in the chairing of the IMTs, is that right?
Yes.
It is. And what I'm going to do is I'm just going to pick up on some references, and then I'll maybe ask you to help us a bit. And again, I'm going to give you a caution that we've been giving to all witnesses, and to help, I hope, reassure core participants as well. The purpose in doing this is simply just to get an understanding of whether or not it's accepted that the things being said were said.
Okay.
The question of whether or not the events described were accurate or not is for another time.
Yeah.
So just staying then on the first page, on page 343, we see there's a reference to 11 patients by this stage meeting the case definition.
Yep.
And if we go over the page, please, Mr. Russell, to page 344, we see under case definition that we just, that's helpful, thank you. And we'll just go through this in detail. It says, it was pointed out that the numbers of bacteremia have not increased, and there's reference to an epidemiology report. And then there's a reference to it being the nature of the bacteria that we're concerned.
Yeah.
And then at the end of that paragraph, it is likely that CLABSI work and excellent practice has driven rates of these down. The organisms we are seeing are environmental in nature and associated with water and soil.
Yeah.
And can you, there's been quite extensive redaction here. Can you say whether you can recall, and please say if you can't, can you say whether you can recall there being any mention of whether or not any of the organisms identified were associated, were said to be associated with dirty water?
Yes. So, well, I can say that, as that minute points out, that the concern wasn't so much the total number of infections, it was the nature of the infections that we were getting. And on the background, as it talks there, that we were seeing these infections despite changes in nursing practice, line handling practice, the way the lines were being put in. And so one would hope that if one's instituted change, that would actually decrease the number of infections. So the fact that they're not decreasing is of concern rather than the fact that they are increasing. And the other thing is that it's the type of infection they are. So as it says there, that these are environmental gram negatives that we're seeing. So I can't then make the distinction that they would be waterborne, but they were, and that water was in the hospital. But the concern is these are environmental gram-negative infections that may be part of the water supply.
Yeah, and just on the point of detail as regards whether or not you're able to recall anyone saying that any of these pathogens may or may not be the sort of thing that you expect to find in dirty water. Is that something that you recall or not?
No, it's not. Well, it's not something that I recall.
Thank you. And just again, picking up on the detail of what's on this minute, if we go a bit further down the page, please, Mr. Russell. So, yeah, the bottom paragraph, please. And if you just take a moment to read the first two sentences, please.
From Dr. Inkster.
With the presence of Pseudomonas.
Okay, yes,
sorry.
okay.
Let me know once you've done that.
Yeah, okay.
And I think we see the same thing mentioned in the paragraph above, and by the same thing, I'm referring to chilled beams.
Yeah.
Can you say whether you can recall there being a discussion around a concern about chilled beams?
Yes.
Thank you. Now, if we go over the page, please, to page 345. And can we enlarge the top paragraph, please, Mr. Russell? Thank you. Again, Dr. Murphy, just take a moment to read that and tell me once you've done it.
Yep, I've read that, yeah.
And do you have a recollection of a discussion of that nature? And if so, are you able to help us a bit with what you understood it to mean?
Yes, so I do have a recollection of that discussion. I think what Dr. Inkster is pointing out here is something called the negative predictive value or the positive predictive value of a test.
Could you say that again?
Sorry, the negative predictive value or the positive predictive value of a test. So the absence of a positive result doesn't mean that the bug isn't there. It just means that your test isn't very good at picking up the bug. And I think that's what she's saying here. So she's saying that there's too much emphasis being placed on negative results. So in other words, the fact that you don't grow something doesn't mean that it's not there. It just means that your system hasn't grown it.
Thank you. And just again, to complete the picture at this stage, if we go to page 346, please, and if we just enlarge the section under hypothesis. And again, just take a moment to read those and tell me when you've done that. The two paragraphs under hypothesis.
Yeah, okay. So I've the two paragraphs under hypothesis, not the paragraphs under HIAT.
No,
Yeah,
just the,
yes,
yeah.
so that's fine.
And again, just can you confirm whether, as far as you can recall, those were the hypotheses that were being discussed at that
Absolutely.
point?
Yes,
Thank
they
you.
were.
Okay, we can put that to one side, please, and move on to the next IMT in August, which is at page 348 of the bundle. And again, we'll just pick up on some references. And just on the first page, again, we see that this is an IMT that you attended.
Yeah.
And that there's been a change of the chair by this stage, is that right?
Correct.
Yeah. And is this an IMT you have a recollection of?
Yes, it is.
Thank you. And if you go over the page, please, to page 349, and if we enlarge under incident update, if we enlarge that section. You take a moment to read the paragraph beginning the hematologist oncologist, and then tell us when you've done that.
Okay. Yep, okay.
And can you confirm whether you have a recollection of a discussion along those lines?
Yes.
And are you able to say who it is that's likely to have said that, or rather which group of people, if I can put it that way?
Yeah, so it would certainly have been the doctors in the room.
Do you mean the clinical doctors?
The clinical doctors. So I can't remember which of my team were there, but, it would have been myself, Dr. Ronge, if he was there, Professor Gibson, saying that we require a safe environment to treat our patients, and we were very clear all the way through that, as you alluded to earlier, what our job was to treat children and young people with cancer, and we needed our facilities and managerial colleagues to provide us with the environment to do that, and we were seeking assurance that we did have a safe environment to treat those high-risk patients.
Thank you. Now, if we could, in a sense, are we to take from that this is a record of the concern that was being set out by colleagues?
Absolutely.
If we go over the page, please, Mr. Russell, to page 350, and if we can enlarge the bottom two paragraphs. And if we just take matters from the reference to the Great Ormond Street Children's Hospital, do you see that?
Okay. Yeah.
And if you just read from there till the end.
Okay. Yeah.
And then if you could go, please, to page 353. Mr. Duncan, can I just interrupt before we finish? It's the reference to Great Ormond Street Hospital, where they reported 4 gram negative bacteremia within its patient population, but none within the nature found during this incident. Now, I think I can guess what's being meant, but within the nature is a kind of odd way of putting it.
I would agree with you, and I had a similar anxiety. What I read from that is that Great Ormond Street had reported 4 gram negative bacteremias, but none of those were environmental. That's my reading of that sentence.
Right. Thank you.
Thank you, my Lord. And if we could go, please, to page 353 under AOCB. The group agreed that a peer review should be carried out of Ward 6A from someone who works in a similar ward, Great Ormond Street or Leeds Children's Hospital. So just pausing there and taking these last two references, what was your understanding of what was being discussed in relation to Great Ormond Street and what was being discussed as regards the peer review?
Yeah. So the Great Ormond Street in this context is because, or I'm assuming is because we had got data from them previously. So they'd already provided us with data. Leeds, because Leeds is a big children's hospital, they've got a very well-established pediatric hemato-oncology unit. And I think this reflects the concern amongst clinicians that there was a change in emphasis with a change in chair, and that the reflection was that this was normal and there was nothing to be seen here. And so we thought it was important that we got external review of the number and type of infections that were being seen within our unit, because frankly, hospitals don't publish this kind of data. So although it's, for us, it's, we can say, well, we've not seen this before, and doctors' training is such that you do tend to move around hospitals. So, I mean, if I use my training, for instance, I trained in multiple hospitals. I mean, so many that I can't remember how many hospitals I've trained in, but it's more than 10, more than 15. And I hadn't seen this pattern of infection before. Now, that doesn't mean that it doesn't happen elsewhere. And as I alluded to earlier, pediatric hemato-oncologists are unusual beasts in that we like everything to be evidentially based. So that in the absence of evidence, we find disturbing, just generally. So we would have, or for us, getting someone outside to come in to say, actually, do you know what, this fits a pattern that we are seeing in our own hospital, you have nothing to worry about, would have at least given us a comparator. Or conversely, if they came in and said, you are quite right to be concerned about this, then that would amplify the concerns that we had, and that we would then hope that those would be accepted and taken on board by managerial colleagues.
Thank you. That's very helpful. I indicated earlier that towards a later stage of your evidence, I'm going to ask you to just help us understand a bit more about why you and our colleagues thought what you were seeing was unusual. And I think you've identified, as it were, two of the possible sources that I'm going to, or rather, possible comparators that I'm going to ask you a bit about. One is your own personal experience of what you've seen before, and the other is what's being seen on other similar hospitals. Is that right?
Yep.
Okay. Now, just in terms of what you said a little before that about a sort of change of approach, and as I say, I'm only interested in the methodology, no more than that. What I took Dr. Chowdhury to say of this stage was that the process up until this point had been that the suspicion of a connection to the environment must remain until it is disproved.
Yeah.
Was that what you thought?
Absolutely.
Yeah. And at this point, she indicated things changed to the opposite. And I took her to say that essentially the approach became the suspicion had to be positively proved if it was to be maintained. Yes. Is that right?
Yes. And, it's the tenor of the meetings went from let's try and find out what's the cause of what is being seen, and I think an acceptance that there was an increase in number of concerning environmental infections, to one where there wasn't an acceptance that there was an increased number of infections that we needed to be worried about, and that therefore there was no concern that they were environmentally linked.
Thank you. Now, just to move us a little bit further forward in the chronology, we've had evidence this week that the consultant body wrote to the chief executive to seek an external review, I think in the way that you have just described. And my question is this: are you aware of such an external review being done?
I'm aware of Professor Stevens' external review, but at the time of that letter being written, I don't think there was an external review done on the back of that letter. I think there were efforts, I was told efforts were made, but it was actually very difficult to get people to agree to come and do an external review.
Yeah. Dr. Chowdhury said in her evidence that she understood there to have been some difficulty in getting somebody to do it. Was that also your understanding?
That was my understanding.
Do you know where you got that understanding from?
I think from managerial colleagues and at a children's hospital level. And I can understand why, if someone asked me, for instance, to come and look at a problem like this in another hospital, you would want to have a team that could do this justice, and it would be a very difficult external review to do, and that's out with any of the media attention there would be to any external review that came along. So I can understand why individuals may look at that and say, no, not for me, thank you.
Thank you. Now, if we move a little bit further forward in time, please, to the next stage of things. The period from end of August until the reopening of things. And I'm going to ask you to look at a couple of IMTs that you were at, and it's really just to clarify a bit of your evidence, if I might. And Mr. Russell, could you take us, please, to, in bundle 1, page 354? Again, I think we see it's an IMT of the 6th of September, and we can see that you were present.
Yeah.
Is that right?
Yeah.
And if we go over the page, please, to page 355, and if we enlarge the top paragraph. And I'm really just sort of wanting you to notice the discussion involving you. And if you could read from that sentence until the end of the paragraph.
Yeah. Okay.
Now, you do deal with this in your statement, and again, reminding us all that other than you, no one mentioned here is giving evidence at this chapter of the hearing. And I just noticed what was being said in the final sentence about the advice that this technology should not be deployed for these patients. Can you say, well, before I ask you this question, in fairness to you, if I ask you to now look at another IMT, could we go to page 360, Mr. Russell? We'll come back to this one, but it's just to let you see something. And it's an IMT of the 13th of September.
Yeah.
It's the one immediately after the one that we've just looked at. Not sure whether you're noted as attending at it or not. I don't think you are.
No, I'm not.
In fact, your apologies are noted.
Yeah.
The reason I'm asking you to look at it is if you just look at the minutes of the last meeting in the second paragraph, there's a reference to that section, page 2, first para. Have you got that?
Yeah.
Just take a moment to read that. Page 2, first para, Dr. Ritchie and Dr. Murphy.
Yeah.
Now, I don't know how these alterations to minutes work, but I do notice that but what's set out there doesn't contain that final sentence.
Yes.
And can you do you have anything to say as regards what we might take from that?
I think you do well to note that final sentence has been removed, and I don't know why it's been removed.
Yeah, the reason I, as a matter of fairness, put it to you was because I think in your statement that you say you have a recollection of the sentence in the first IMT.
Yes.
You have a recollection of that being said. It might be, and I simply do not know. I have no idea what the position on this is. But I think as a matter of fairness, I have to draw that to your attention because it could be that somebody has said that that's not their recollection of what was said.
Obviously, that could be the case.
Yeah.
That could be the case.
And I guess where I'm finally getting to is, do you have a recollection or are you dependent on the minutes as regards to
No,
this?
I have a recollection that if we go back to the previous minute.
So page 355.
That where we have Tom Steele advised that this technology should not be deployed for these patients. I remember that meeting and I remember that we had a discussion about chilled beams. And listen, again, as a doctor, to know what a chilled beam is, that shows you, why we're here today. This was around, though, the specifics of what was allowed in technical minutes, and we'd talked earlier about the hotel accommodation in the new children's hospital, and by that I mean what the physical infrastructure is like, and there are technical manuals, these SHTMs, that dictate to a certain extent what is and what is not acceptable, and this is going to the core of what is and what is not acceptable. And my reflection had been that just because it's not said it's not acceptable, that doesn't make it acceptable, and that the individual mentioned there in that final sentence had said that he didn't believe that this technology should be deployed for these patients.
Thank you. Now, if we move on, if we can go back to the page 360 of the same bundle, please. And if we go, please, to noting, as we already have, that this is not a meeting that you were at. Mm-hmm. But before we look at a particular passage, can you recall whether you were, or are you able to say whether it is likely that you would have been updated about what was said at this meeting?
Yeah, I can recall that I wouldn't have been updated about.
Say that again, sorry.
I can recall that I would not have been updated about this meeting. One of the things about the whole of the governance around this was it was very difficult to maintain a narrative arc through the IMT process, because if you weren't present at a particular IMT meeting, there was no formal dissemination of ongoing decision making. So it did make it difficult to be kept formally aware of where things were going. Obviously, we had discussion amongst ourselves about what was said at the last IMT, but frequently we wouldn't see the minutes until the morning of the next meeting, or they would be given to us at the meeting itself.
If we go, please, to page 362. And if we just enlarge the top third, really the second paragraph, I'd like to look at. And if you're not able to recall the precise chronology in any of this, please do say. Mm-hmm. But just noting that what was being said there about the ward being microbiologically safe at the time, can you remember if that was something that was fed back to you at that point?
It wasn't fed back to me as an individual. but I would have been made aware of that by colleagues who were present at that IMT meeting.
Yeah.
And, you know, I think if either Professor Jones or either of those two gentlemen had said that it wasn't safe, then the consequence of that would have been we would have had to moved off Ward 6A. So, you know, it would have then been obvious that that was their opinion.
Yeah, yeah. Now, can I ask you, please, again, just picking up on some of these references so that we've all seen the important documents. If we move through the bundle a little further, please, to page 373 of bundle 1, please. And I think we can see this is an IMT of the 8th of October, and you're recorded as attending, at least for some of it. Is that right?
Yes.
Maybe just picking up on that point, maybe it's not possible to generalise, but it'd be helpful to hear your thoughts on this. How long did these meetings tend to last?
Yeah, they could go on for a very long time. So I know that this one started at 1600 and I left at 1655. That's likely because I had to go to the ward to do some clinical work. They could last much longer than an hour. I mean, 2-3 hours.
Yeah, I mean, I think we can see, just even staying on this page, we can see that Professor Craig White attended the meeting up until 7:20.
Yeah, that's not unusual.
That wasn't unusual.
No, it wouldn't have been, sorry, to be clear, it wouldn't have been unusual for a meeting to have gone on for that period of time.
Yeah. Why would this one have been going on as long as that, would you think?
No, as I say, I think that the fact that this one went on for 3 hours, 20 minutes, that's not surprising.
Yeah. Why do you say that?
Because many of them did go on for a very long period of time.
And was that's a reflection of what, would you say?
Of the complexity of the situation.
Yeah. And the anxiety of the situation?
And the anxiety of the situation.
And if we, just to pick up on a point of detail, please, if we go to page 378 on this minute, and if we can just sort of enlarge the middle part of the page, please. Do you see the reference to it, the suggestion that this is not a typical outbreak, a pseudo outbreak?
Which paragraph is that?
I'm sorry, it's the one beginning Dr. Decant.
Okay, thank you. Yeah.
Now, can you remember whether you were, it's page 378, and it's about halfway down, Dr. Decant. So there's an expression of belief that this was not a typical outbreak. It was like a pseudo outbreak, perhaps the first described in the world. I suppose my first question is, can you recall whether you were present at that part of the discussion?
Yeah, I don't think I was present at that part of the discussion.
Okay. Do you recall being advised about this?
Okay, so I recall that pseudo outbreak became something that was discussed. I had no idea what was being meant by a pseudo outbreak. I think that's very difficult to define, and I find it interesting that that a hypothesis that is the first described in the world is being taken forward as the most likely outcome here.
Do you want to expand on that a little?
Just that one would want to be very, very sure that one had excluded any other possibility before arriving at a statement that says this is the first time this has been reported in the world.
Yeah. We can put that to one side now, Mr. Russell, thank you. You have got quite a bit in your statement about this stage of things, and we will obviously take all of that on board. If we were to sum up how things stood at this point, I'd be interested in your thoughts on, I suppose, what might be described as the competing or the various considerations around keeping the restrictions on Ward 6A. And what were the competing, if that's the way to put it, competing considerations, thinking very much from the point of view of your patients? What would those be?
So the child and their family has to be absolutely, and their safety absolutely has to be at the centre of all the care that we deliver. So on the one hand, you want to ensure that you're not harming them by placing them in an environment that's inherently unsafe, or by doing things to them that are more unsafe than they need to be. And I choose those words carefully because any medical intervention carries risk. And so you want to make sure that you are not exposing them to excess risk that they would otherwise not be exposed to. On the other hand, you don't want to put undue restriction on families that are unnecessary because there isn't an issue with safety. So, for instance, if you are saying you can't come out of your room because we're concerned about infection within the ward environment, that's going to have, just being isolated in the rooms we've alluded to earlier, can have a very negative impact on the family. So you need to balance up the requirement to keep that child and their family safe with the impact of the measures that you've put in place to try and ensure maximal safety. So there's always going to be a trade-off between those two things.
Yeah, thank you. I mean, if I was to try and summarise the considerations that we've picked up on in the evidence this week so far, including yours, first of all, there's the concern about whether it's safe to open up the ward.
Yeah.
But secondly, something that was emphasised by Dr. Chowdhury is the concern about not admitting sick children, a situation that Dr. Chowdhury described as untenable. Mm-hmm. Was that your thinking at the time as well?
Oh, absolutely. So, you have super regional pediatric oncology units for a reason, and the fact that we were unable to have as open access to ourselves as previously was immensely concerning. So we had, as well as at one point not taking any new patients into the unit, we also increased the amount of what's called shared care that we do. So in other words, children who were becoming unwell with fevers at home were looked after in associated hospitals. So in Forth Valley or in Cross House or Dumfries and Galloway, to try and decrease the throughput through our unit. So there are real concerns that families are not getting the kind of care that we would like to deliver.
Now, I wonder if another consideration was the continuing use of prophylactic medication. And before you answer that question, I'll just again trail where we're going. One of the other themes I'm going to ask you about in a bit more detail is around the use of prophylactic medication. So it's a matter for you. If you want to go into detail just now, please do so. Okay. But equally, I would be content if you kept it at broad strokes at this point. What was that a concern at this point?
Was what a concern?
The fact that there may have been a requirement to continue using prophylaxis if the concerns about the ward remained?
Yes. So in broad brushstroke terms, you don't want to do anything extra to any patient, be that child or adult, because anything that is effective is going to have a degree of side effect. So introducing anything new is great if it improves the situation, but there's always going to be a cost to that. So if the only way that we could keep seeing children within the confines of the QE campus was to introduce prophylaxis, well, on the one hand, the prophylaxis allows you to carry on working. On the other hand, well, what's the side effect of the prophylaxis going to be? So there's always concern that when you're introducing something new, you don't inadvertently add to the burden the patient is going to get.
Mm-hmm. So, I mean, when you take all of these things together with the other aspects that you mentioned, can you say whether, I think you probably already have, whether you agree with Dr. Chowdhury that the situation just couldn't go on like that?
Correct.
Yeah. Now, if we jump ahead a little in time, and again, this is really just more to help all of us to make sure that we've got the timeline. We know that there was an IMT that took place on the 5th of November 2019, and there was a presentation made, I think, by Professor Leonard.
Yep.
And you say some things about that in your statement. I mean, if you were to sort of summarise your thoughts as regards the analysis that was being presented, what would they be?
Well, it was an elegant piece of work.
It was what, sorry?
An elegant piece of work, and it was very well run as an experiment. I just think it was asking the wrong question and interpreted in a way that I wouldn't have interpreted it. So, yeah.
And this is something I'm going to return to later. Thinking about you as a treating clinician, as an oncologist, is the assessment of that work something that's within your expertise?
So the assessment of the methodology, the assessment of the generalizability of it is within my expertise. I'm certainly not expert enough to be able to have done the experiment.
Can you just help us a bit on the bit that is within your expertise? Because you do mention this in your statement, and I wasn't sure I understood what you meant. You said that you disagreed with, I think, the generalization of his results. Could you explain that a little bit?
Yeah, so Professor Leonard had looked at whether he could see whether the type of bug called E. coli were from the same family or not. And so he was looking at their genome to do that. And so that's great. That's a really nice piece of work. But, we weren't interested in well, it's not that we weren't interested. What we were much more interested in was the environmental gram-negative infections rather than the non-environmental gram-negative infections. So by saying that the non-environmental gram-negatives didn't seem to have a familial link or a physical link together, that doesn't mean that you can then say, therefore, the environmental gram-negative infections similarly don't have that link. That was my concern.
Thank you. So if we were to just ask this question then, so at this stage, can you say whether or not you yourself were satisfied that it was safe to reopen the ward?
I think that's a different question to Professor Leonard's experiment. So I was happy is a loaded word, isn't it? I was content that I had been as reassured as I could be by my colleagues that the ward was safe to reopen. I told Professor Leonard at the time that I didn't think his results were generalizable, and that's not surprising. As clinicians and scientists, you will disagree on how you can interpret evidence.
Yeah. Now, it's important, I think, that nobody is misled by the question that I asked there. And in particular, I wasn't suggesting that it was Professor Leonard who advised that it was safe to open the ward. Apart from anything else, we can see from the IMT minute from that meeting that the ultimate decision would be taken by the Chief Nursing Officer.
Yeah.
And if we go a little further ahead to the IMT of the 14th of November, which is at page 402 of the same bundle, thank you. Again, we can see that you're present with clinical colleagues. And I just want to take you to page 403, and underneath incident update. If you just take a moment to read the first two paragraphs, and then I'll ask you a question.
Okay, yeah.
Do you have a recollection of, even in broad terms, of what's set out there being discussed?
Yes, I do.
Are you able to explain it to us?
So my concern was that, so if we take the first paragraph, so we've got a report from HPS that the GGC can lift the ward restriction. My concern was that the absence of evidence isn't absence of cause. And although, as I say there, that the source of infection wasn't found, that doesn't mean that the source of infections was found somewhere else. And so my concern is that if we haven't established why are the patients in the hemato-oncology service getting these infections, then moving back in opens up the possibility that they're going to get those infections again in the future.
Are we to read this, or can you confirm whether we are to read this as indicating a discussion along the lines that there was now advice that it was safe to open, but that you as a treating clinician are continuing to express a concern? Is that right?
Yes.
If I ask you please to look over the page to page 404, and if you look under this the number 7, Mr. Russell, risk management control measures, we can have a look at that. And again, just take a moment to have a look at that, please.
Okay, yeah.
What is it that I'm thinking in particular about the reference to the clinical team being happy? It might go back to what you said a moment ago, and maybe wonder if this is the point in time where this is what's being said. If you could explain your recollection at least.
My recollection of this is that as a clinical team, we had attended many IMTs and there had been repeated assurances that mitigation was being put in place. And despite that mitigation, we continue to have further and ongoing problems. So that the clinical team would be naturally anxious that when we're told that it's safe to go back to somewhere, because we haven't worked out why are these children still getting all those infections, that we are reintroducing children into an environment where potentially those infections are going to come back. And I think at this point, it wasn't so much that we were convinced that there was a a major issue that hadn't been addressed on 6A. It was that we had been reassured so many times in the past, and that reassurance had was given with all due respect and with all good intention, that despite those reassurances, our patients had continued to carry on having infections. So, if you're telling us it's safe to go back, well, okay, we accept that, but we need to have a very clear understanding and perhaps further discussion about why that is the case.
Yeah. Can you confirm whether we've had evidence already about this week? I'm anxious not to lead you on this, as I'm sure you'll understand. Can you recall whether there came a point that clinicians were able to say, well, on what we're being presented with, we are content, if that's the word?
Yeah. Yes.
Yeah.
Yeah.
And maybe it's important at this point to just mention two things. I think our understanding within the inquiry team is that the ward was reopened around about the 21st of November 2019. Would that be right?
That's my recollection, yeah.
And just thinking about, and by the ward, of course, we're talking about Ward 6A, and just thinking about the period since then, throughout the whole of the period that you remained on Ward 6A, did you or your clinical colleagues, or indeed infection control, see anything that you considered to be untoward or concerning or unusual in infections from that point?
To answer that in a way that's useful to you, I'd need to see the infection run charts, and without further study, it would be remiss of me to talk about that, I think.
Can I frame the question in this way? Do you have a recollection of that ever being? Do you have a recollection of there being any concern about a return of unusual infections after matters opened up?
After 2019?
Yeah.
Yeah, I can't untangle when in the timeline my concerns about infections dissipated and disappeared. What I can say is that I have no concerns now, but it's when I lost those concerns I can't say.
I think I'm understanding what you're saying. Am I taking you to say that the concerns that there may still be a problem may have continued past the 21st of November 2019?
They may have continued past that, yes.
But the question of whether you, in fact, as colleagues, saw patterns of infections that concerned you is a different question.
That's a different question.
And what I'm asking you is whether you recall whether there ever were such continuing patterns.
Yes, I don't recall that. That doesn't mean they weren't there.
Yeah. Well, it's only fair, I think, to put this evidence to you that the evidence of your fellow consultants this week is that they have no recollection of such concerns.
Yeah.
I'm not taking you to say anything inconsistent with that. Would that be fair? Thank you. Just one further detail on this chapter, and it's just a document that I would like you to look at, and I know that you have seen before. If we could go to bundle 6, please, Mr. Russell. And at page 10. And you've got before you an S bar. And if I take you, please, if we go to page page 12, B6.12. Just the end of it, yeah. It's an S bar by Mr. Andrew Murray, of Forth Valley, dated the 12th of December 2019. And I think, at least for the purposes of this hearing, I think this is something that's been drawn to your attention. Is that right?
Yes.
Can you recall whether you... Well, sorry, let me take a step back. Having read the document, you'll understand that Mr. Murray was engaged to do a piece of analysis around the prescription of prophylaxis and also the communication around that.
Yes.
Is that right?
Yes.
And it's our understanding within the inquiry, and we'll hear from Mr. Murray next week perhaps on this, that this came about as a result of the Oversight Board's work.
Yep.
Can you yourself recall having any meetings or discussions with Mr. Murray?
Oh, yes, absolutely. So I should say, just for clarity, that Mr. Murray and I now work very closely in the Managed Service Network, of which he's the chairman and I'm the clinical director. But I remember meeting with Mr. Murray in the clinical director's office in the ground floor of the Royal Hospital for Children to discuss this.
If I can take you in particular to, if we can have a look at the paragraph on, sorry, Mr. So can we go back to page 10? And if we go to the paragraph that begins, hemato-oncologists have provided confirmation.
Okay.
You got that?
Yeah.
Hemato-oncologists have provided confirmation that they are reassured regarding the safety of the water and the environment in 6A based on evidence from a range of sources and the long-standing improvement approach to infection control. Can you say whether you recall discussing that matter in your discussions with Mr. Murray?
So, no, I think that was, we didn't have an active discussion about that because it was statement of fact. My meeting with Mr. Murray was more around the practicalities of using prophylaxis and going on from ciprofloxacin to Torlox. So as a meeting between two clinicians, because Mr. Murray's an ENT surgeon, it was very much on the basis of, okay, how are we going to move forward with prophylaxis and what are you doing and have you got the governance structures around that, rather than a discussion about what's happening on 6A at the moment.
Yeah. I mean, if we maybe just break that sentence into two questions.
Yeah.
With the first question being whether you yourself provided that information to Mr. Murray, and the second question being whether what is set out there would be something that you would have accepted.
Okay, so the way I read this, and I don't have a direct recollection in answer to your question, the way I read this is that that we would have confirmed, having been asked, that we were reassured by the safety rather than doing the reassuring ourselves. And that may be semantic, but that's the way that I read this. And yes, at that point, I was similarly reassured that the 6A was a safe place to have children and young people with cancer. I mean, again, if we weren't reassured that it was safe, we wouldn't have carried on treating children in that environment.
Thank you. My Lord, I wonder if this would be a convenient moment to break, unless there are any further questions arising on this document from your Lordship's point of view.
We'll take our lunch break. I mentioned that the BBC had asked for facilities to do some filming, and you would notice the camera crew this morning. My current understanding is that the BBC will not be requiring further facilities, but I'm just alerted to that being a possibility. So if people are wanting to use, the bottom line is that if people want to use the hearing space over lunch, they're free to do so. We'll sit again at 2 o'clock.
Okay.
Please stand.